You are listening to the
World Extreme Medicine.
The World Extreme Medicine
Podcast.
In this episode, I'm speaking with Henrik Hedelin around hemorrhage control in austere environments. So what I wanted to do is really discuss the approaches, techniques, and strategies to achieve bleeding control in trauma in the austere and indeed resource-limited environments. So to do this, we have Henrik with us. He has had a number of trauma care experiences in various environments, and he's going to share his insights on assessing and managing bleeding emergencies in the field. So we're going to examine both best practice for stopping life-threatening hemorrhage, but also Henrik's anecdotal experience of hemorrhage control before getting the patient to definitive care. So to this, we have Henrik Hedelin with us. Henrik is an experienced orthopaedic surgeon. Henrik, welcome to the podcast.
Happy to be here.
Henrik, I just wondered if you could just unpack a little bit of your background for listeners.
Well, I am a consultant orthopedic surgeon now, and my interest in wilderness medicine and basically aid work started out when I was a medical student. So I went to Afghanistan back as a med student, then Iraq. And after that, I've been to quite a few places, Yemen, Somalia, Kenya, Nicaragua, India, and now latest in Ukraine. And I've been teaching wilderness medicine and different aspects of that for more than a decade now. But of course, there are many of the people listening to this podcast who have even more experience than I have. But I do believe I have some key points I would like to share for those interested.
No, that's fantastic. And it'd be great to get those and tease those out of you, actually, Henrik. If we could just maybe start with getting your experience with indeed hemorrhage control and just some of your anecdotal experience with hemorrhage control.
Well, in war zones, of course, there's a lot of bleeding victims. There's blast injuries and gunshot wounds and landmine victims and things like that. But when we talk about austere environments, we very easily get into the military sphere. And if we would like to broaden the horizon a bit and talk about resource-limited environments, which I think would be more relevant to the majority of listeners to this podcast, this concept of hemorrhage control without a complete ER or ICU at your hands, it becomes relevant in quite a few instances. I mean, I saw a lot of bleeding in Nicaragua, for example, at a hospital. Were brought in straight from the street. And as soon as we take away our favorite talismans and our favorite tools and tricks, it's easy to become confused and not do the right thing in the right order.
No, indeed. And actually, like we'll probably touch on within the episode around keeping things simple and indeed doing the basics well. But could I maybe get you to speak to Henrik around some of the typical mechanisms of injury that pre-hospital providers and indeed humanitarians might encounter that when they're presented with major bleeding?
That's an interesting question because it's of course so dependent on setting. In a war zone, it will depend a lot on where you're at. I mean, if you're very close to the front line, there will be certain kinds of mechanism of bleeding, and if you're just a few miles out from there will be different mechanisms of bleeding, because the true catastrophic bleedings, they will either have been treated or died. And that's why, I mean, if we talk about T3C and the March concept, the massive hemorrhage, I believe that we'll probably touch on this later, but if you haven't seen a lot of bleeding, it's very easy to say that any major bleeding or potentially major bleeding is a massive hemorrhage, and probably it's not, because in most cases that person would have died if it's not a military setting with somebody with a tourniquet in their pocket, right? But in civilian resource-limited settings, it's quite often interpersonal conflicts like machetes or things like that that will cause a lot of bleeding. And of course, road traffic accidents happen in the remotest of places.
No, indeed. And actually, looking at to your point actually, and it's very difficult to teach around this, but it's definitely observations over time is that you're right, different pathologies or different mechanisms of action actually lead to different presentations. So you can get a lot of arterial spasm with more blunt trauma, and you get a lot of this arterial recoil, and almost this fundamental hemorrhage control, which occurs from an organic perspective, versus, like you said, more an incised wound, which maybe causes a whole different kind of range of bleeding, and maybe the more mass hemorrhage or external hemorrhage that you can see, and then, like you said, the crush injuries, which might be more less apparent to the eye, but might be bleeding into internal cavities, so there might be no visible blood loss. Doesn't mean they're not bleeding. So it's very difficult, isn't it, to discern and differentiate, but nonetheless all surrounds mechanism, and probably all has various different approaches. But could I get you to speak to when you initially arrive at scene, or in a humanitarian context, maybe a war-torn context, around identifying life-threatening hemorrhage? Because, like we've just reviewed, that there's many different kind of pathologies and presentations. What do you look for?
Well, being an orthopedic surgeon, I mean, we're always made fun of, and maybe I will, give you more ammunition for that, because I like to keep things very simple. And if you, of course, you probably have, but if you ever seen somebody who is truly exsanguinating, they are actually going into hypovolemic shock, I would say that just looking at that person in the eye, looking at their face, you can quite often tell if they're bleeding out. And that first piece of information, I mean, if you look at somebody and your gut feeling tells you this person is bleeding, it's probably true. And everything looks like a nail if we only have a hammer, right? And we love to use our numbers and all of that information we usually get at the A&E. But looking at somebody's face and looking at the color of their face and looking whether they look bled out, that is probably the first thing I would ask people to do. But if you've never seen it, it's difficult to teach. And the second thing would be the obvious, like, are they bleeding out? There's a lot of blood on the floor, so to say, blood on the floor and 4 more, but people tend not to actually try to look at blood on the floor. How much is it actually bleeding? And to the untrained eye, I mean, 2 teacups of blood splashed over a large surface would look like a bloodbath, but it's not necessarily a big bleeding. And on the other hand, I mean, certain settings, you can hide a lot of bleeding. I mean, on snow or sand, they can bleed out and you only see a small stain on the ground. So you have to be a bit of a detective there and try to understand what actually happened. And then there is the mechanism. As you put it so well, a lot of blast injuries or sometimes also gunshot wounds, they actually don't bleed that much right when you get there because of the vasospasm. There are great studies on landmines where they don't bleed out as quickly as you would think they would, even though they have almost had their leg amputated. While on the other hand, if you cut somebody with glass or a knife or machete in the extremities, they will bleed out a lot quickly. And then thirdly, now moving into what we usually taught, like how do you actually measure how hypovolemic somebody could be? I am a great fan of just checking the pulse. And if somebody has a radial pulse, I'm kind of happy for the moment, at least. And those would be the initial assessments I do before moving on to what we normally focus on, like blood pressure and all of these other capillary refill and all these details.
So listen, I would agree with you actually, Henrik. And what I'd say to your point is that actually the the Mark 1 eyeball, so just a quick end of bed assessment. You're right. So pallor is a visible indicator. Diaphoresis is actually also quite sensitive. So is someone sweating, and respiratory rate, all of which are the confluence or the result of endogenous catecholamine release, so your homemade adrenaline, and actually that that circulating adrenaline will cause all those things, and those can be garnered within 2 or 3 seconds from the end of the bed. And like you said, the confirmation can be feeling a pulse, it can be looking at the mechanism, but that elevated respiratory rate, that excessive sweating, that pallor, especially in a warm or hot place, are actual markers of severity for me. And you're right, it doesn't take long to differentiate that. But could you maybe then speak to some of the core principles around effective hemorrhage control? It is nuanced, as you said. Not all hemorrhage control is external, which makes it extremely difficult. If it's internal, they might need someone like yourself, a surgeon, on an operating table. But what are some of the core principles that you teach, Henrik?
I will answer that question, but firstly, I would like to say I'm very happy you mentioned the respiratory rate. There is a great paper by Husum and colleagues that show that in a pre-hospital setting, respiratory rate is the one parameter that has the best predictive value for survival in trauma, and it's that one parameter that we tend to neglect. So I agree completely. And I do agree with the pallor and general appearance of the patient, and usually they also have a bit of panic in their eyes, which is subjective but hard not to see once you've seen it. And moving on to the core principles of hemorrhage control, your second question, I like to keep it down to basics again. It's easy to strain at gnats and swallow camels, right? And we always like to stick to what we're good at. And the one answer to how to treat bleeding is stupefyingly simple. It's to stop the bleeding. But if you talk to an anesthesiologist about hypovolemia, of course, they will talk about what you should infuse, cyclopropyl and things like that. But the treatment of bleeding is to stop the bleeding. That's always first line, right? And there are two more things that we can do to decrease bleeding. And I would like to mention them now, otherwise they always end up as like add-ons, but they are actually core principles in the pre-hospital or pre-hospital environment. And that is to protect the clot and to keep them warm. And these two factors are always not addressed sufficiently, always, in my experience. So because they're like, oh yes, and we should do this too. But rather than to remember that's actually one of the most important things. So those two things are two of the most important things we can do, especially in a low resource environment. But moving on to stopping the bleeding, which was step one, of course. People know this, but of course the first for any external bleeding is pressure. You start with pressure because you can buy yourself some time there. And then what you do next is dependent on where does the bleeding come from. And being an orthopod, of course, I prefer to talk about extremity bleeding because that's what I know most about. But direct pressure must be maintained. And people who are not used to seeing bleeding wounds of any kind, they tend to put pressure on the bleeding. And then they wait for 10 seconds, and then they take off the dressing to see if it stopped bleeding. Which is, of course, stupid when you say it like this, but within the stress cone, people will do stupid things. So keep the pressure on, and if you're going to do something else, keep the pressure while you're doing that. That's simple things, once again. And secondly, you have to decide, is this a wound that can be, where you can apply pressure and some sort of continuous pressure will be enough, or is this a large hole that you need to pack? And if you need to pack it, you need to pack it properly. And here comes when we come down to it, it's knowledge does not equal skill. And to pack a wound sounds easy when you say it, but to actually pack a wound is actually a skill set that needs some training to do. Because if the cavity is large enough, direct pressure will probably not stop it. And I like to tell doctors, like, imagine it's a nosebleed. You won't stop a nosebleed by just plugging the nose or very slowly. You need to actually make a tamponade. And that requires the pressure of the stuff you're putting into the cavity to be greater than the pressure of the blood flow. So practicing and learning how to properly pack a wound is an essential skill. And then, of course, we move on to tourniquets, which is the favorite tool of people. And there's a time and place for tourniquets. It's not a bad tool. But I am convinced that people who don't see a lot of bleeding put on a tourniquet on anything that bleeds because it feels so safe, because then we stopped it. And I'm currently writing a commentary on this issue with some colleagues from the United States and Burkina Faso and from Ukraine. And one of the key points here is that, like, the tourniquet is in practice quite often, more than 60%, applied to cases that would not need a tourniquet. And secondly, it's quite often not working. So it's simply not tight enough if it's there. So using a tourniquet is a great tool, but it should be reserved for the cases where it's needed, and it needs to be put on properly. And that's also a skill set.
So I would fundamentally agree with you, actually. And within 20 years of post-op care, I think I put on about 3 tourniquets in my time. Because quite rightly, as you say, there is actually some basic principles, which if you adhere to, direct pressure, wound elevation, wound packing, and you do them properly, actually negate and mitigate the need for tourniquets a large percentage of the time. And we'll go there in a second about proper tourniquet application. But to your point around temporizing a wound as well, so a couple of things and flaws that you've seen, which I totally agree with, is one is not putting enough focused or focal direct pressure on for long enough, and another is putting expensive bandages on wounds not tight enough. So they're actually acting as an expensive sponge, and all they're doing is absorbing blood. They're not acting with the direct pressure, looking at OLAS dressing with the focus cup on the wound. So to your point around doing the basics, the absolute fundamental basics well, which is direct pressure for a large amount of time, elevation of the limb, wound packing properly if it's needed. And it would be really interesting to do some empirical research on this and how many wounds, or indeed mitigating wounds mitigating that don't need a tourniquet would be prevented. And again, the sequelae and the second and third order effects of that would be potentially life-saving and limb-saving, and a lot of ischemia saving. And so that would be really interesting, actually, Henrik. And as you said, it seems to be a default mechanism, and indeed there is a lot of maybe fear or worry, or indeed that's the first thing people go to and then they negate these very simple modalities, which a lot of times will actually work quite effectively if done for a proper duration and a proper extended time. Could you maybe, one thing you mentioned, which is really interesting, is exposure. And I think rarely do people, even advanced clinicians, get exposure to florid proper bleeding or critical care bleeding from point of wounding, because it's either happened and it's a retrospective case because they've bled out, or indeed there is no real true life-threatening bleed, because by the sheer fact when they have responded, the patient's still alive, they've done their own hemorrhage control. But so this exposure piece is really interesting to getting the right education out there. But could you maybe speak to some of the, so you've said that tourniquets don't necessarily be they're not necessarily applied properly. Could you maybe speak to proper application in your mind?
I will gladly do that, but I would you say so many interesting things. I would like to reflect a bit on what you said. And first of all, I completely agree with the shiny new toy curse that we have. Like if we have a hemostatic bleeding bandage, we tend to use that instead of proper technique. I mean, of course you should use that bandage if you have it, if you use it properly, but it doesn't compensate for bad technique, right? And secondly, when it comes to tourniquets, it's all setting dependent, and I will happily speak more about that later. And all evidence regarding civilian tourniquets is from high resource settings. There was a great review written by a Norwegian team 3 years back, and all the studies that were included in their systematic review were from either North America, Europe, Australia, or Israel, with one exception from China. And in those cases, for police officers or lay people to put on a tourniquet, I mean, the cost is not that high, is it? Because they're going to be in a hospital within 30 minutes anyway, most likely. So in those cases, it's okay to be rather safe than sorry, maybe. But if you're moving away from there, and now we're on this podcast, it's for people who do not necessarily work in a city with a nice hospital 20 minutes away, then you have to think ahead and what will happen next. And there I would also like to mention that this is personal opinion, but a tourniquet is not a bad tool to bridge a good packing. Putting on a tourniquet to pack the wound and then immediately or after 15 minutes convert it to the packing makes it easier to pack potentially. So once again, it's a tool, it's not a solution. But then regarding tourniquet application, firstly, I'm usually not one for supporting expensive brands or specific things, but I do believe one need to use approved tourniquets. Currently, the only organization I know about is the COTCC, which will approve different, like 10 or 20 models right now that are approved. There are probably other great ones out there, but we don't know. And I actually ordered a bunch of tourniquets from Amazon, the cheapest ones I could find, and just to try them out. And when I did courses with them, half of them broke before being applied 3 times. I mean, they literally fell apart. So if you're going to use a tourniquet, use a proper tourniquet. And then there, of course, there's the discussion about high and tight, or a few inches above the injury. And this is also a pseudo discussion for me, because the high and tight principle has 2 reasons behind it. And the first one is legitimate, and the second one is, in my opinion, bogus. And the first reason would be if you're in an under fire situation and you don't know from where it's bleeding, but it's bleeding from the leg. Sure, put on a high and tight tourniquet and drag the person out of the trench. That makes sense, right? The second theory would be that it's more effective to put a tourniquet on upper limbs, like this, the humerus or the femur, rather than lower leg, lower arm, where you have 2 bones. But there are some studies done on that, and also from surgery, we know that a proper tourniquet on the lower parts of the leg or arm, they work if you put them on hard enough. So to me, that's a non-question. A high and tight tourniquet is a very situation-specific solution that is always only a bridge. And I have very sad stories from Ukraine about this. Multiple, not 1, not 10, but 20 or 30. And the second thing would be improvise tourniquets. And in short, I would say that except for a very small subgroup of people, don't do it. because I mean, special forces, other people who train this every day, if you're a complete nerd and spent hours practicing, sure, you could probably make an improvised tourniquet work. But for most people and most healthcare providers, you have not practiced enough, which means that if you try to put on an improvised tourniquet, you're going to have a venous tourniquet, and you're going to spend a lot of time trying to get it there instead of doing proper basic management.
So looking at bleeds, which so I agree with everything you just said, actually, Henrik, and I think that it's a lack of, again, probably a lack of exposure to actual bleeds, and this is something really interesting around being in surgery and doing surgical intervention on a lot of different patients. You see these critical bleeds, and actually you see the nature of bleeding and how to stop bleeding, and again also how long it takes to stop the bleeding, how effective wound packing actually works, because the exposure's there from your practice. But could you maybe speak to sort of non-limb bleeds, so truncal bleeds, and indeed or junctional bleeds, and how you would recommend, what interventions you recommend for a junctional or non-tourniquet bleed?
First of all, the basic principles you said, direct pressure, etc., etc. And what I'm going to say now applies both to extremity bleeds and junctional bleeding, and that's of course, the junctional compression. You said direct pressure and elevation. How effective is elevation? Yeah, probably a bit, but it won't save the situation. When it comes to proximal compression, it can be very effective in the right hands. I just talked to a colleague the other day who met a South African trauma expert who could, with his thumb, stop basically any artery. Like would lose the pulse in the foot or the hand within seconds. But he was an expert. He knew exactly what he was doing. And I would say even most doctors, maybe me included, would struggle to actually compress it enough. Does that mean it's a bad method? No, it's an adjunct. Sure, if you have spare hands, use it, press, do whatever you can, as long as you do the other stuff first or simultaneously. Junctional tourniquets, the military use them, and they're probably good. I have never used them for real, so to say. But it's unlikely that you, as an expedition doctor or in any real case scenario, if you're not working with the military, that you would happen to have a junctional tourniquet at hand. So it's definitely one of those toys that's only there for a very specific scenario. When it comes to external junctional bleeding, there are certain techniques that you can do to actually get pressure on it. I mean, bleedings in the neck, for example, you can put proper pressure there. I mean, there are stories of people who kept people alive with fingers inside the wound for hours. And you can put a pressure dressing on it using proper techniques like the armpit or keeping your arm raised and wrap it over the arm. That was not meant to be a thumbs down, by the way. And as always, don't be afraid to actually get your fingers bloody. I mean, blind clamping is terrible. But if you get your fingers into the wound and you can feel the bleeding, by all means, press on it.
No, absolutely. And I would advocate any first responder or indeed provider gets to your point, to the source of the bleed, especially with a Silox or some of these more artificial hemorrhage control agents, because actually they need to be at the source of the bleed. So the pseudo clot, which is created by these adjuncts, actually need to be at the source. And quite often, you're right, they're not at the entry of the wound. It's quite deep into the wound itself, and actually you don't get a feel for the anatomy or indeed where it's bleeding until you really engage. And again, with the wound packing, as we were saying before, Hendrik, systematically thumb feeding it into the wound tightly, feeding it from one hand to the other, then really packing it tight. Once it's in, wrapping that with a direct bandage. And then maybe again something else on there, but just really systematically and thoroughly packing a wound. So there's focal pressure fundamentally inside of the wound. Again, it's an exposure thing, but to your point around just meeting the physiology as to where it is and engaging with it and not being scared of it. And also, not necessarily scared, but getting eyes on the wound itself. So taking the clothes off, removing anything which is going to interfere with your intervention is absolutely key, and is again to your point.
I would like to add there, I agree with everything you said. Like when it comes to the pressure dressing, at least in Sweden and probably many other parts of the world, doctors are really crap at making dressings because we never do that. Like, okay, we're bad at packing wounds as a collective, but probably even worse at making dressings. And it's the most dangerous stage, I mean, it's a Dunning-Kruger curve, right? Is to not understand that you don't understand. And to actually practice how you make that dressing tight enough on that spot is a challenge. There are some tricks you can do. I mean, there's this Israeli bandage that's basically a broad elastic band that can be used both as a tourniquet and as direct pressure for the wound. And there is the Slishman version, a wrap that you basically press on the wound and you can increase the pressure however much you like. And that makes it easier to apply pressure straight to the wound. Once again, it's really nice to have principles, but if they don't work in practice for most people, they don't work. And I really think that medical teaching globally has a problem with trying to create a golden standard that everybody should achieve. I mean, if you know people are not going to be able to pack wounds, either you can train them, but if that is not feasible because a number of people or whatever, then you have to come up with what's the best solution in that scenario. I mean, the algorithms we should use to treat or I like to say pre-hospital bleeding, because pre-hospital is basically you have a mobile hospital, you have the ambulance or whatever. But the algorithm we should use should probably not be the same in rural Cambodia or in Ukraine or in Chicago. Probably we should approach those situations differently, not only because of the training of whoever sees the patient first or the injured first, but also because of all the logistics, not only evacuation time, but also where are they evacuated to. So these standards should be adjusted to the setting, and that is confusing.
Absolutely, Hendrik, and I think you're right. The teaching needs to be adjusted to the system, as you were saying, and actually be aware of where the definitive care lies, and actually what the ceilings of care should be on scene. And to your earlier point around a tourniquet can be wrong hands if it's misapplied, and actually understanding that actually as an intervention, if it is needed, there should be appropriate and application, but there's wider appreciation of where that patient's going and what the ceiling of care will be. Just shifting pace slightly and pivoting towards pediatric patients, Hendrik, looking at pediatric patients which have got bleeding complications, could you maybe speak to anything else or anything different that you would do, or indeed any red flags which you might adjust when dealing with pediatrics?
Well, firstly, most doctors would know that they compensate when they bleed out. So a lot of the signs and symptoms that we would see in adults, you don't wait for them to treat everything early. That's a very important point. And once again, the small hacks that are quite often forgotten. I mean, we don't want the blood pressure to be raised unnecessarily in a pediatric patient. So what's the best method not to raise the blood pressure? Well, make sure they're not in too much pain and make sure a parent is there. I mean, those two things are very important.
I would agree, absolutely, and I think vicariously treating a patient through, or a pediatric patient through the parent sometimes is the best way to keep them calm. And again, sometimes even putting the patient on the pediatric patient on the parent on a trolley bed or gurney or somewhere to as you said, calm the heart rate, calm the respiratory rate, get a sense of control of the situation, so you can start to visually see the wound itself and start to treat effectively. But again, that often involves the parent if the parent is present. Henrik, could I get you to speak to how you see some of the latest bleeding guidelines and how you see? So you've said some really interesting things here, which is actually quite interesting from a number of reasons around systems-based approaches, and actually de-emphasizes tourniquets in certain circumstances, which I agree with, and I think there should be a lot more training around some of the more fundamental basic bleeding principles and longevity of time of those interventions. Could you speak to the guidelines around bleeding management, where you see you've spoken to a few studies which are already ongoing. Could you speak to what you'd like to see maybe in the guidelines and maybe some of the pre-existing guidelines at the moment?
Yes, of course, I do not know all the guidelines. And there are probably lots of smart and experienced people who are doing lots of guidelines that I might have missed. But speaking from the point of view from a humble Swedish orthopedic surgeon, I'm very happy to see that the T3C has been updated recently based on the Ukrainian experience. And I think that's great. They put a lot of emphasis on training, and there has been like quite a few papers the last 2 years on this, Quinn, Holocomb, etc. And also a few papers from Ukraine, which is really interesting, because quite often we make up ideas and then we export them without referring to the actual source, so to say. And the new guidelines, they emphasize the conversion of a tourniquet and that fact that they should be converted as soon as possible. If they are put on, they should be converted as soon as possible. And in Ukraine, informally, in the hospital I was working, approximately 80% of all the amputations we did was because of the tourniquet and not because of the injury. Those are staggering numbers. And it's really scandalous. And those Ukrainian soldiers and that entire system, they were trained by European medics who taught them exactly what they were supposed to, because that was the system. So no shame on them. But the entire concept of T3C and all of that, it was born from the Afghanistan and Iraq wars, where the soldier was lifted out with a helicopter immediately. And that's not feasible in Ukraine. Nor would it be if NATO fought Russia, for example. You can't send a helicopter to the front line. But I'm not a military man, I'm a complete civilian. And this is applicable to quite a few civilian contexts as well. You put on a tourniquet, great, it's a good tool, you needed to put it on, sure, but now what? And we have this 2-hour rule, but most doctors or paramedics, they push that issue in front of them. Like you drop them off, and then from there they move on to the next place and next place. Somebody has to be able to say, all right, this tourniquet we need to try to convert it. And as long as somebody is not completely exsanguinated, you can pack a wound and you can loosen the tourniquet and see if it works. It sounds easy, but people don't do it because people are scared of it.
So I would agree with that, and I would say that as well, be the one to quality assure the tourniquet itself. I've had a number of experiences. One in particular where I went to a civilian in London who had been stabbed in his brachial artery, and brought him into what was the Royal London, one of the major trauma centres, one of the most eminent major trauma centres in the UK and Europe. Only really, so never really quality assured that it was a belt actually that had been used, and only to see the cardiothoracic surgeon take off the tourniquet, the belt, and just apply pressure with a finger. And actually, what that did to me was, this was in front of a whole theatre of people, down in the ED. So, but a whole cardiac of 15, 16 people there, all ready to receive this patient. And actually, what that illustrated to me is take your time to assess the wound, take your time to sequentially move through a stepwise process. Be the one to quality assure the basic interventions over time, to make sure that they don't work, and actually a drastic intervention like a tourniquet, if it's needed, fine, but a lot of times it's not actually needed. And to your point around actually what's the next steps after a tourniquet, and actually if a tourniquet has been applied not by you, does it need to be on? Again, this is controversial, but actually, you especially if you're the senior medical person in charge of either the scene or indeed in the hospital, looking at what the next steps are. Is the surgeon there? Have you got a surgical team around you? And again, I'm not advocating for taking every tourniquet off straight away, but certainly it's better to be the one that's quality assured the intervention, and then understand the next steps for that patient. Because quite rightly, as you say, if everyone's coming in with tourniquets, you can absolutely guarantee 6, 7, 8 out of those 10 patients might actually have just you can save the necrosis, save the ischemia, save the pain. You can use the fundamental basic principles and actually save a lot of the sequelae and second and third order effects.
I concur, but I would like to say that actually it's probably not controversial to convert to tourniquet. The guidelines say so now, since 2022. It's just that people don't dare to do so. And it does not need to be a doctor. It does not need to be a surgeon. And once again, if somebody's hemodynamically stable and talks to you, I mean, as long as you don't you said take them off. By all means, don't take them off. Just loosen them. And the cost of doing that is pretty low, because if the bleeding starts and you can't control it, then just tighten it. It sounds simple, but it's not a dirt to. So that's my take on tourniquets. Basically, it's a great tool, and in certain settings, like where evacuation times are short and the qualifications of the initial healthcare provider is low, I understand that it has a place. That's why Stop the Bleed has become a big thing, and it's probably might save a lot of lives in the US and many other places. But there are many settings where the same approach will create lots of problems. I mean, the number of amputations within Ukraine was quite staggering again, and they all had high and tight tourniquets, which means that somebody with a small wound in the calf had a high femoral amputation. And that's not one case. Once again, it's 5 a week, maybe, in one place. And that's not okay. We can do better than that. And some of the recent papers, they say that training is the silver bullet. And I of course, that is true, if training is feasible in that setting, to that number of providers.
No, Henrik, absolutely. And I think we'll as we come into land in the conversation, I think that's a great thing to leave listeners is that fundamental principle that actually training is where the information and indeed education and indeed the evidence can be proven and or argued, and then that can start to affect practice in a lot of cases. Those numbers are staggering from Ukraine, and like you said, there's a lot that can be done to mitigate that in practice. But I just want to thank you for your time. I think some of your reflections are very powerful because not only are they anecdotal, they're empirically proven as well. But you see them, and you've seen them in various contexts, in war zones and humanitarian sectors. So it adds weight to your observations. But just is there anything you'd like to leave listeners before we close?
Yes, I have a few favorite things to tell students and colleagues, and it's being an orthopod, of course, I'm going to have to address open fractures and blunt trauma. So there are a few things, and one thing is open fractures. All right, so open fractures generally don't bleed that much. There's a common misconception. Of course, you can have an arterial bleeding, but usually they don't bleed that much. But they bleed a bit, and if you have multiple injuries, that will add to the blood loss. And in my world, once again, you don't prioritize the simple, important things. The best way to start to stop bleeding from an open fracture is to reduce the fracture. And pre-hospitally, a lot of doctors or paramedics, the worse a fracture looks, the less inclined they are to reduce it, but the greater the reason to reduce it. And I don't even say reduce, because then people think it's like that orthopaedic reduction where you're going to try to make it perfect. I just say to grossly make it straight-ish. Because it has two functions, or three actually. The first one is you can't pack a wound with a bone pipe sticking out of it. You have to get the bone inside the body to pack the wound. Or you can't even apply proper direct pressure on a bone because it will leak out next to it. And the second is that if you don't reduce a displaced fracture, you can't fixate it. And if you don't immobilize it, it's going to bleed because it's not immobilized. So with any lower extremity fractures, you need to align the body and make a package. And that's probably the best thing you can do for the entire system. So putting something soft under the knees to give you a slight bit of flexion, putting something soft between the knees to make sure you are not in valgus, and then tie the feet together. That takes less than 20 seconds. And then you created a package that decreases the bleeding from the fracture, enables the packing of the wound, and this is the important part also, it protects the clot. And a pelvic binder without making that package is useless. If you're going to, then it's a different question about using a pelvic binder, but that's a separate topic. But making that package is probably one of the most important things we can do for any injuries to the lower extremities that involves fractures, or the pelvic fractures, of course. And I've seen quite a few cases in ERs where people are basically spread eagled with a pelvic binder on. And doesn't make sense at all. But it's so simple, people forget it.
Yeah, absolutely. And I think that alignment is absolutely key. But the package it doesn't stop or indeed just start at the pelvis. It goes all the way down the body. But reducing the fracture, like you said, bringing it back to normal anatomical alignment. And I think that one of the most important reasons, fundamental reasons that needs to happen is, something you've notioned towards, which is that actually, if there, especially for a mid-shaft long bone fracture like the femur, actually the muscles act like sponges, so they'll just start to absorb the blood into the muscle, and again that's occult bleeding that won't necessarily be visible, but will certainly be accruing within the muscular compartments. So actually, drawing drawing the limbs out to normal anatomical alignment, so you're stopping almost the potential space for that bleeding, or at least reducing it, is absolutely key. But as you said, bringing the feet together so there's no splaying of the pelvis, and indeed of the feet, and starting to package the lower limbs as such is absolutely key. Absolutely.
And then we need to say just a word about femoral traction, traction splints. And once again, people confuse the tool with the purpose, right? People see a femur fracture and say, oh, it needs a traction splint. If you have a hypovolemic patient, make the package, align the limbs, splint one leg to the other, 20 seconds, and you're done. And then if you have the time and capacity and knowledge and tools to add a traction splint, by all means, feel free to do so. But it's not the treatment for a femoral fracture.
No, absolutely, and I think that's a key point as well. And sometimes speed is of the essence here. And like you said, 20 seconds to align the limbs and splint the feet together, and indeed the pelvis. But absolutely, and you can start to make a plan to extricate that patient. Henrik, I'm mindful of time, but I just want to thank you for your reflections and indeed your thoughts, because they're accrued from a various number of missions and deployments around the world, and so they are extremely insightful. So thank you.
Well, it's been a pleasure to be on the cast, and thank you for talking to me and reflecting on this very relevant issue.
Thanks, Henrik.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.